So when we talk hypoalbuminemia, we tend to talk and divide it up into non-selective decreases in albumin. And these are usually loss of albumin. And it's non-selective because you also see a decrease in globulin. So it's a decrease in albumin plus a decrease in globulin, hence why it's called non-selective. We've already talked about these before, so I'll only briefly go over them. And then we have selective decreases in albumin. And so this means that it's just a decrease in albumin, not globulin. And this also includes loss, and it includes decreased production of albumin. So we'll go through these in a little bit more detail. So of course, when we talk about non-selective loss, we're looking again at albumin and globulin decrease. And the cause we've talked about a lot is blood loss. And I know you know how to evaluate blood loss, but thinking about it, how would you describe what happens? Well, you're going to look for an animal who has an anemia. And unless it's a horse, you're going to look for an animal who has a regenerative anemia. Of course, if it's pre-regenerative, then it may not quite be, the retics may not be up yet. So you're going to look for that anemia, you're going to look for it to be regenerative, but now you know how to look for a few other things. So you might look for a history that suggests trauma. You might look for a cause. So you check platelets. Are they less than 25,000 to suggest spontaneous hemorrhage? You're going to look at your coag tests. Is there an increase in PT or an increase in PTT or both? You might look for a source. So what might a source be? Well, we've talked briefly about urea or BUN increasing relative to creatinine to suggest GI bleeding, so that's a possibility. You might look in the urinary tract to look in the UA to see if there's bleeding there. Is there iron deficiency to suggest it's an external type of hemorrhage? So you kind of already know how to do that one. The next one is protein-losing enteropathy, abbreviated PLE. And of course, I'm sure you remember from histology the various layers of the intestine. And there are various layers in the intestine, of course, that allow for, oops, that did not work, that allow for absorption, and there's all sorts of villi. This is my very terrible view of the intestine. And so, of course, you can have infiltrative disease. This is let's say this is some sort of infiltrative disease getting into those various components of your intestine wall. And so options are going to be inflammation, and inflammation could be idiopathic inflammation, like an inflammatory bowel disease. It could be infectious inflammation, such as maybe fungal disease, or perhaps some sort of other severe bacterial infection or disease that hasn't killed the animal. And then, of course, there's neoplasia, which can be an infiltrative disease as well. And the one that tends to be more diffuse is lymphoma. So in this case, if you see an anemia, the anemia would be anemia of chronic disease most often, although you could potentially have iron deficiency if there was infiltrative disease causing blood loss from neoplasia. And you may also see a decrease in cholesterol because when you can't absorb nutrients in the intestine, that may include lipids and things. So you may see that decrease in cholesterol. The last one that you may see, or that may cause panhypoproteinemia, and that's the other name for this, is when you have non-selective losses, panhypoproteinemia, are going to be exudates, so effusions or burns. And so you would need, for the burns, you'd need a history, and exudates, you're actually going to look at something, the fluid characteristics. So is it abdominal fluid or pleural fluid? And you would look at that and look for a protein in that inflammation. So I'm going to mostly skip loss. So now we're talking about selective decreases of albumin, and this can be either loss of albumin, and this is via the urinary tract, or it can be decreased production of albumin, and this, of course, the liver is what produces albumin. So this means that there's decreased production of albumin by the liver. So causes include, and we touched on this before, inflammation. So albumin is a negative acute phase protein. That means that in states of inflammation, it decreases. So negative acute phase protein, you decrease production of albumin due to inflammatory mediators. So you'll have a decrease in albumin, and of course globulin would be normal, or if there's chronic inflammation, it could be increased. So the inflammation can be acute or chronic. Of course, chronic inflammation, you might expect then to see that increase in globulin. The other one we talked about when we talked about clotting factors, of course, is, so if the liver makes albumin, if you have failure of the liver, so hepatic failure, the evidence for hepatic failure, of course, would be concurrent decreases in things like urea, glucose, cholesterol, and an increase in clotting times because you have decreased production of clotting factors by the liver. So hepatic failure, we'll talk about that later on. The last one are going to be things like starvation, anywhere time you have decreased substrate. So look at the body condition score, evaluate your patient. So now we're going to talk a little bit about urinary loss of albumin. In terms of identifying decreased production, let me just say this quickly. Inflammation, of course, you need to look at your CBC for inflammation, for support, and I know you know how to do that, so I won't worry there. And hepatic failure, you're going to look at these other indirect liver function tests. Okay, now let's move on to urinary. All right, here's my favorite, the glomerulus plus tubule combo. And of course, blood comes in through your afferent arteriole and then is filtered by your glomerulus. And your glomerulus is, again, all of these capillaries, the wall of the capillary surrounded by other structures. And what winds up getting through into the tubules is, it's a cell and protein-free filtrate. So it's free of proteins and cells. And the proteins it's free of are albumin and anything larger. So it excludes albumin, meaning albumin stays within the blood. So the protein, so your UA should have no protein in it. So that should be negative for protein. So what's your glomerulus? So here's the wall of your glomerulus, and you can, or of the capillaries within it, and it's fenestrated endothelium, and it's actually surrounded, the endothelium, by structures which are called podocytes, but that doesn't matter. And so on this side you have your vessel, and on this other side you actually have your tubule. And so the filtrate is going that way, and albumin is supposed to stay on this side. So in something called glomerulonephritis, which has a number of causes, you get inflammation or antigen-antibody complexes or various other things that allows this fine barrier between the vessel, so the blood, and the tubule to become damaged, so that albumin winds up on the other side into the filtrate, so now you get positive urine protein. So that is the glomerular source of albumin. And again, this results in protein-losing nephropathy. And it's not that it's necessarily the most serious, it's just that this can create a lot of protein in the urine. And the disease can spread beyond just the glomerulus, and we're not going to go into all of those details. So there's also the possibility of your tubules reabsorbing some protein. And so with something called acute kidney injury, so maybe, and we'll talk about this when we get to renal system, there are some small proteins that get into your, smaller than albumin, that get into your tubules and have to be reabsorbed. Remember that whole counter-current mechanism that overlies the kidney, it is what reabsorbs anything that winds up in the interstitium. And so with injury, some of that protein won't be reabsorbed and it'll wind up going out into your urine. The last thing to talk about is the distal the actual distal tubule reabsorbs some protein, or excuse me, produces some protein. So in very concentrated urine samples, so this is concentrated urine samples, so a high urine specific gravity, you can have protein in a small amount, so usually 2+ or less. And that's normal protein. And I probably just confused you because that's a super confusing topic. So let me tell you how you actually identify this. So what you look for is you look for a decrease in albumin, of course, and you then look at your UA, and you're going to have a positive urine dipstick. And we'll talk more about this in the renal section. So you have a positive urine dipstick, and you can also do special tests. One of them is called an SSA test, and it would be positive, but not everybody does that. And then you can do something called a urine protein to urine creatinine ratio. And we'll talk about these tests as we actually move on in the course. We're not going to talk about them now. And so if you imagine, right, so here's your urine, which now of course is blue. Oops. We'll just take that box away. So if you have very, very, very highly concentrated urine, so a high urine specific gravity, you remember your distal tubule, as I just said, so that's this part here, it normally makes some protein, and that will then allow, in a high urine specific gravity, a little bit of protein in your urine. So a very small amount, again, usually trace or 1+. But if you have a lower urine specific gravity, any protein is considered more significant. So we're not going to get that complex yet, but essentially 3+ or 4+ in any degree of urine protein is, in any USG is very concentrated, whereas 2+ or less is as worrisome as 3+ or 4+ in a low urine specific gravity urine. So again, probably just confused you, but we'll go over that a little bit more. For our purposes now, we're going to look for a decrease in albumin and a positive urine dipstick, and that's going to tell us that we have urinary loss of albumin resulting in our hypoalbuminemia, and that is called protein-losing nephropathy, and it's most often glomerular.